You have a client that comes in and says, I'm feeling exhausted. I'm waking up at 2 or 3 in the morning consistently. My libido is gone. I'm experiencing brain fog. How do you approach these conversations in a way that is different than most medical providers do?
Cannot address sexual health in women without talking about our brains, our mood, our nervous system, our blood flow, our heart health, our cardiometabolic health. Hormones just get the party started.
I personally took GLP-1s so that I could lose 14 pounds. And one side effect that I had that I did not realize could be from this.
A woman who's feeling really good in her size 2 jeans that she couldn't fit into for 20 years, she's not going to tell you that this also has destroyed her sex life because she's afraid you're going to take that GLP-1 away from her.
PT141, the libido peptide.
Why are we having like this leftover sex at 11 p.m. at night?
Thank you, Jackie. I mean, welcome to Lesson Translation, the podcast where desire gets decoded. I'm your host, sexologist Natassia Miller, and there's one thing before we begin. If you hit follow wherever you listen to our podcast, it will help us grow and bring you even better guests and conversations. It takes 2 seconds, it's free, and it means the world. Now let's get into it. Jackie Giannelli, welcome to Lesson Translation.
Thank you for having me. This is a pleasure to be with you here in studio in New York.
So you are a board-certified family nurse practitioner specializing in women's health, longevity, and sexual medicine. You have your own private practice where you serve women in the New York metropolitan area and in Connecticut. You're also a clinical strategist for the new Carolyn Rowan Center at Mount Sinai, which, for those who don't know, is a women's health initiative. So what don't you do?
Well, a lot of things. I'm terrible at spreadsheets, for example, and taxes. I don't do those either.
But I'm really excited to have you here today because I have a lot of clients who are in perimenopause and menopause. And last year when I turned 35, I started feeling a tangible shift in my energy, sleep quality, disposition, skin. And now I really understand what my clients are actually going through. And the funny thing is that sometimes it can also just feel like you're so young going through all of this. And then you ask your medical provider for help, and for them, they'll look at your lab results and you'll be like, but you're within range, you're normal. So my first question to you is, when you have a client that comes in and says, I'm feeling exhausted, I'm waking up at 2 or 3 in the morning consistently, even when I do everything the right way. My libido is gone. I'm experiencing brain fog. How do you approach these conversations in a way that is different than most medical providers do?
Pretty much in every way that is possible is how I approach it. But the thing you said just now is that you were describing ways that women feel in their day-to-day. And for example, there is no clinical diagnosis for brain fog. You just can't find it, right? There's no code for that. And if we can't bill for something based on a code, a diagnostic code in conventional medicine, then there's not a medication for it, then there's not a system set up around it. And that is just so incongruent with how women's bodies are built, with how our hormonal trajectories are transpiring over the course of our normal, natural hormonal health transitions, perimenopause being one of them. And so it doesn't surprise me at all to hear you say that around age 35 is when these subtle changes started to happen. We know that women's ovaries are sort of like the director and CEO and COO of our bodies. And
they age twice as fast as our biological age.
That's correct. Right. And so it feels like a slap in the face to an otherwise young person to all of a sudden be experiencing these shifts at what feels like a normal, very, vital time in their life when they're doing a lot and in the thick of their career and having potentially young children running around. It's really just a confusing time for people. And we lose 90% of our ovarian reserve, our hormonal reserve, and our hormonal function by age 35, which is why, they're
90%?
90%, which is why if you're
insane.
35 or older, it's considered a geriatric pregnancy, right? If you're getting pregnant at that age, which is, again,
that's a horrible
term. Let's retire that immediately, but it is still the vernacular. And so with loss in our reproductive capacity is also comes this overlap with perimenopause. And these are not distinct phases of our lives. These are overlapping windows, late reproductive stage and early perimenopause. And that has to do with an overall decline in not only the quality of our ovarian function, but the quantity of the hormones we're producing. The first one to sort of go is progesterone. And that is why women who are starting to hit 35 and creeping closer to 40 might notice subtle changes like not being able to sleep through the night or sleep as soundly as they were before. Brain fog, for example, definitely is top of the list. Loss of libido as testosterone is declining even before 35. In our early 30s, late 20s, we're starting to notice subtle declines in testosterone. And so it hits this place where, we're maybe done having kids or we're finishing up having our kids and now we're excited to build a career, do whatever comes next for us, and boom, there it is.
Yeah, that is really frightening. And the funny thing is when you start thinking about, okay, so then what is it that I do in order to start feeling better? And like my personal situation was when I did go to my primary physician and did a swath of lab tests, I am technically, within range, but something that I found really helpful on your website is you have a free guide that indicates like what is quote unquote normal versus optimal and what are the markers that you should be looking for. Can you share a little bit more about that, please?
Sure. So hormonal health testing is controversial for many reasons, mostly because our hormones are constantly fluctuating left, right, up, and down on any given day, depending on where we are in our cycles as women. So you're just throwing a dart at a dartboard and randomly checking where it may land. And so it can be confirmatory or overly confirmatory of something like full-blown menopause, when in reality, if I had checked it 3 hours later, those numbers could have looked very different. So I use hormonal health testing as sort of the third guardrail around my clinical an evidence-based database that I use to help understand what's going on in your body. And that's, to your earlier question, sort of what I think I do differently than, let's say, a conventional primary care doctor, is that I'm thinking very much about where you are in your monthly cycle, but also in your perimenopause trajectory. And I use your symptoms first in order to help me understand where you might be in the throes of all of that. So it very much matters to me when I take a history about what's going on with your cycle. Is it getting heavier, shorter, closer together? Is PMS getting worse? What parts of your cycle are you noticing these symptoms be more profound for you? And so that's where tracking and my patients giving a really good history over time is so key. And then I might match that with objective data like lab work, for example. If I know what day of your cycle it was drawn on, that does help me give a little more specificity around what might be going on. And then I can work backwards from there and say, okay, well, you're 37 and your cycles are getting a little closer together and you're telling me your PMS is out of control. And so maybe, in my mind, I'm thinking progesterone is probably the likely thing that we're deficient in at this time, or maybe just suboptimal, right? Normal and optimal are different.
Yes.
It's very normal what you're describing. These are normal transitions. It doesn't mean we have to accept sort of the resultant symptoms that accompany that. And we can do things to address it, but we have to understand what hormones are where in order to really provide that backfill, those solutions that are meaningful and feel right in our body.
Let's be honest, it's really hard to feel sexy when your vagina feels off. If you're bracing for irritation, infections, or another post-sex UTI, it's almost impossible to stay present in the bedroom, and that's why I love Momotaro Apotheca. Their salve is my soothing balm for external irritation when my vulva feels raw from tight clothes, sex, or workouts. It calms the dryness, the itching, that everything feels irritated sensation. And their suppository supports you internally when yeast or discharge feel off. And their UTI supplement is my I've got you for those after sex moments that used to mean a guaranteed UTI. Now, when I know that my vagina is cared for, I show up way more confident and relaxed in bed. If you're interested, you can build your own ritual at momotaroapotheca.com with code LUST for 20% off. I think it's wild how there's so many stories of women who just hear from their medical providers that, this is just a normal part of aging, that there's not much that they can do. There's a lot of like real worry about prescribing hormone therapy and, facing any backlash or litigation. I think that's changing now just from the conversations that I'm seeing on social media with more and more women being prescribed estrogen. Mm-hmm. And I think that's great. Like, we're going in the right direction, but unfortunately the medical gaslighting is still very real.
Very real. We just don't have providers that were trained. And it's not just the training. Anyone can go take a weekend course now, really in anything, and be considered an expert overnight. To me, it's the years of actually being with patients, because that's where you really learn how to do this nuanced work. These are symptoms that don't just trace back to one solution. Oftentimes, hormone therapy is part of the solution, but it's never the only part. And we have to really work with women to address their biopsychosocial and emotional health beyond just a prescription. And sadly, our clinicians, even if they are educated and do have a baseline understanding and want to be helpful, they don't have the capacity, the system support around them to deliver this care in a sustainable, meaningful way.
Yeah, I love that you brought that up, because a lot of my work is really focused on the psycho-emotional part of how they're, relating to their partners, how they're, feeling themselves, and understanding like the shame and the anxiety and the guilt that can come with, and just the lack of sex education in general, right? Which I know is a part of what you do as well with your clients, which is so important. Mm-hmm. I have a great story. A friend of mine said that she was in a relationship and she had no desire to have sex with her partner. And so she begged her doctor to prescribe testosterone to her. And the doctor did prescribe. And she goes, suddenly, I wanted to have sex with everybody, including the guy that was cleaning the windows at the office, except for my boyfriend at the time. And that's when I knew that the relationship was the problem, right? Like, it wasn't my hormones, so to speak.
That's right.
And I think the moral of the story is that we can often think that our hormones are the problems, and if we just tweak them and it's just like a quote unquote easy fix, that the rest is going to fall into place, but that's not true.
So not true. Hormones are just the unlock, and they're oftentimes sort of the minority stakeholder in the situation. Women's brains, as I've heard you say numerous times, I know we're so aligned here, are our biggest sex organs. Yeah. And it's interesting that you share that story. I think, maybe her hormones were okay, or maybe they could have used a little bit of a boost, but women need novelty, anticipation, a feeling of safety, right? And so maybe there was some of that was missing. And so we cannot address sexual health in women in particular without talking about, our brains, our mood, our nervous system, our blood flow, our heart health, our cardiometabolic health, all of that. It's not one simple thing. Hormones just get the party started.
Exactly. But talking about hormones, testosterone specifically, because I hear so many women share, especially when they are postpartum. I've heard people tell how when they're prescribed some testosterone gel that they're able to feel already a shift in their disposition, in their libido. But unfortunately, we actually don't have a female-branded testosterone prescription. It has to be a male one.
We're writing millions of prescriptions each year for women, all off-label, because there is no FDA-approved product, and there has been petitioning at the FDA and a lot of advocacy around this topic, led by many women's health advocates. But it's still hard when this is never going to be a branded product, or at least not anytime soon, because there has to be money in doing that. And so we do still have to work with what we've got, and luckily, there are guidelines that the academics set, the International Society for the Study of Women's Sexual Health, which is ISWISH, the Menopause Society, have all kind of come together and said there is an evidence-based way to do this. We have plethora of evidence to suggest that hormone therapy, testosterone therapy is safe, effective, necessary for our well-being beyond just our sexual wellness even. And there's a right way to do it that doctors, providers of any kind can freely look up today and follow quite easily.
Yeah, that's great. So when you're thinking about taking testosterone or estrogen or progesterone, how should people think about the combination of these hormones and how they relate to each other and how they should be prescribed?
I mean, there's a lot to say about that. These are all three key sort of star players among many in a woman's body. And estradiol certainly is the master conductor of all of it. And it's not, to your point, just the absolute amounts. Like, I should take 5 milligrams of testosterone per day. Yes, but what is the relationship to the amount of estrogen you have? And so where you are in your cycle, where you are in menopause, I'm going to treat a 67-year-old woman very differently than a 37-year-old woman,
right,
based on what her brain is really asking for and, what her other health factors are to consider. For someone who's more at risk for breast cancer or more at risk for heart disease, those are not contraindications, but rather considerations, in how I strategize. This is where clinical strategy and the art of medicine really comes into play, and having these conversations with your patients has to happen.
Yes, but I heard that you should, if you haven't gone through menopause yet, you should be prescribed your estrogen with your progesterone.
So progesterone, think about progesterone as serving many functions in the body, but in the hormone therapy conversation, it primarily exists in order to protect the uterine lining or the uterus from unopposed estradiol. Estradiol is like fertilizer in your garden. It makes your beautiful flowers grow lush and green and pretty in spring. And then eventually you need a lawnmower, right, to come and keep it tight. And so that's progesterone. And progesterone also helps protect against uterine cancer for that reason. And it also, when the withdrawal happens, is when you get your period, and the withdrawal of progesterone and estradiol eventually is what causes you to actually get a period and bleed. And so in the years where you are still cycling on your own, you're still making your own progesterone. So we still need to add it back, but it becomes even more, I would say, more of a necessity in my postmenopausal patients, because those patients are no longer ovulating. Therefore, they are no longer making their own progesterone. Therefore, if I'm going to give them estradiol, which is probably going to make them feel a whole lot better, if they have an intact uterus, meaning if they haven't had it removed for some reason, those patients do need uterine protection in the form of a progestogen, which is progesterone.
Okay, let's talk about that, because people often throw around these different terms, right? You have estradiol, estrogen, progesterone, progestin, bioidentical. What is the difference between them?
I mean, so bioidentical, all that means is that it is molecularly the same as the hormonal structure that your body endogenously makes, that your ovaries are already making. So when I give that to someone, I can confidently say, your body knows what to do with this. It's exactly what your body already sees, knows, and loves.
Okay.
And that we also know is much safer in the body overall, right? We know now there's less risk of things like blood clots and strokes when I give somebody oral bioidentical estradiol versus an oral estrogen, like what's in a birth control pill, for example, just because it's a lower dose, but it's also bioidentical. Progesterone is more interesting in that the bioidentical progesterone, the body it's not the villain that it was made out to be. It's really the progestins. That is what was studied in the WHI, which was the study that happened over 20 years ago now, that caused everyone to throw out their hormone therapy and to really starve an entire generation of women of hormones that could have protected them against things like osteoporosis, et cetera. It's a whole other story.
We're going to talk about that.
Yeah. But those we used synthetic hormones, meaning not bioidentical estradiol, but more importantly, we used progestins in the study that caused all this uproar. And the reason that is important is that we think that is the very small increased risk of breast cancer that we saw in those women had to do more with the use of progestin and not with the estrogen at all. In fact, we know that estrogen does not cause breast cancer. We saw in the Women's Health Initiative study that when estrogen was used alone, whether it was bioidentical or not, in fact, it was not in this study, we saw a decreased risk of breast cancer in that subset of that study. So today, when we think about hormone therapy, especially in women as they age, I try to take women off of synthetic progestins and put them on bioidentical progesterone as their long-term strategy for their overall health and well-being.
Okay, that's great.
Yes.
That is very clarifying.
Good.
But yes, I love that you brought up the WHI study that took place. My understanding too was that one of the big errors that they made was that they were testing on women who were in their 70s and had spent 20 years without estrogen in their bodies. And so, they had plaque buildup and all of these additional risks that led to the calling off of the study and the entire drama around prescribing estrogen. Because of that, the lesson was women shouldn't be given estrogen if they haven't had it in their bodies for 20 years, because it can certainly create a stressful reaction, right?
Well said. Yeah, exactly. And I think that was what was misinterpreted and what wasn't reported on, and it was oversimplified. These were women who, yes, to your point, were already experiencing things like heart disease, and we were giving them in this study, we were looking at these women to see, does the reintroduction of hormone therapy benefit them in some way in the setting of these comorbidities? And the answer was it absolutely does not, and hence the study was stopped. But that was very much misinterpreted and extrapolated now to much younger women. I mean, sadly, women who are having risk-reducing surgery at a younger age, for example, who have their ovaries removed because they're at high risk for breast cancer, for example, many times these women are not offered hormone, which should be called hormone replacement therapy.
Right.
And that is so detrimental, we know now, and honestly, medical malpractice, in my opinion, to remove a hormone from a woman's body and not replace it, especially in our younger women who now have 2/3 of their life to live. And we're really setting those patients up for, massive heart disease, potentially progression to type 2 diabetes, osteoporosis, dementia, and the like. So it's the timing and the dosing is just as important as what hormone we're giving them.
One thing that I constantly hear from my friends and from clients is truly the fear that hormone replacement therapy will lead to an increased risk in cancer and specifically breast cancer. And so I'm glad that we're starting to have more of these conversations and people are understanding the misinformation around it, because this has truly impacted so much of our quality of life. And naturally, if you're not feeling good in your own skin, you're not going to be open to sex.
Right.
Right?
Right. Yeah, I think it's interesting. I would say, to your point about cancer fear, it is so different now. In fact, I love to say that I'm so infrequently having this conversation now about my patients. Maybe it's self-selecting, but where I see patients, they are coming to me and they've been pre-educated. We've done such a good job of raising this conversation that I think women now they're still getting over some of the shame or the guilt of feeling like they need something that they can't provide for themselves in some way, rather than a fear of cancer. It's sort of like this, I can do this mentality, rah, when this isn't a crutch. This is the same way that you would wear glasses if your eyesight was, not allowing you to drive a car. You would never consider not putting, contacts or glasses on. Well, this is the equivalent of that in the hormonal health space. And so, yes, I think this is not, you don't have to feel completely broken. You don't have to feel like you can't get out of bed in the morning and everything is awful and you want a divorce before you ask for help. We can feel fine and go to your provider and say, I kind of feel blah. I hear that all the time. Just flat. I feel like not that excited about anything. And I'm going through the motions and, I'm being, a decent partner or, a reasonable mom, but they kind of lose themselves in the process. And I think there's this yearning for that like reclaiming of who they were in their most vital state, and they miss that person.
To feel alive and energized.
Feel alive, exactly. And that is not, I think, I encourage women to go to providers, obviously maybe not your gynecologist in that setting, but to a provider who understands hormones, sexual wellness, longevity, and can pull from a lot of different, toolboxes, essentially create a master plan for you that is not just for today, but helps you kind of strategize about where you want to be and how we're going to get there together. That to me is really that's the holy grail.
When these women come to you and they share that they're feeling flat, do you find that it tends to be because of a medication that they're taking, whether it is an SSRI or a GLP-1, for example?
Sometimes, and I certainly screen for those things. I think there's a lot of dopamine thievery happening out there right now.
Yeah.
In the forum. I think it was going on for a long time, but we're constantly scrolling on our phones, right? How much, you don't like something, you just swipe and you get to the next thing. Mm-hmm. And so there's this drain of dopamine happening all the time. I think, yes, there are many medications we know can cause sort of a flat affect. Mm-hmm. I mean, the overprescribing of SSRIs, believe me, they have a place. Our mental health is so important. And for many, many women, they are an unlock for vitality because you cannot be present in your body and in the world if you're highly anxious, for example. So there's these are all dose dependent. But giving an SSRI to a woman, for example, who is having new onset anxiety and she's 42 years old and starting to experience cycle changes, that's not first line, right? First line is actually hormone therapy in that patient potentially. So we're overprescribing SSRIs. There's other medications, beta blockers, other things, of course, that can cause flattening. But GLP-1s, I mean, this is New York City, and there's not a patient in my practice at this point who hasn't at least asked me about a GLP-1. And you and I have had this conversation together before because, I've been prescribing GLPs to men and women since about 2018, 2019. And when the stronger versions like Mounjaro and Zepbound first came out, we were really excited about them. And there were people that didn't need to lose a lot of weight. And so we were getting them up to these higher doses. And being in a sexual medicine practice at the time, we naturally were asking our patients about their sexual wellness.
Yes.
And hearing from people that they were unable to climax, that they just felt like completely uninterested in sex all of a sudden. And of course, to men, that's devastating. Right. And so once we learned we had to back off a little bit on GLPs, which, blunt reward seeking pathways, not just for food, but for all things.
Right.
And in order to have arousal and climax and get excited about sex, you need to, it's reward, right? You're seeking something. Your body
is an incentive motivation system.
Exactly. And so I find that I'm much more conservative, especially in my female patients, about dosing GLPs. I really take more of a microdosing strategy in my patients who are using them, even in the beginning, even when we're just getting them started and they have 75 pounds to lose. Very rarely am I just throwing the standard dose at them,
right?
Because I want to see how it's going to impact them beyond just with hunger suppression.
Yeah, I think that's so important because one of the things that we talked about is how women tend to be overdosed. And then they are frustrated with how it is impacting their vitality and curiosity and also their libido as a consequence.
Yeah.
And their medical providers aren't doing anything to adjust. And so they're like, well, I'm finally feeling, good in my skin because I'm losing the weight that I've always wanted to see lose. But at the same time, I'm feeling that flattening. And that can be really, really frustrating. It almost feels like you can't have your cake and eat it too.
I know, and there's that trade-off, and it's a conversation that really should be had when you're discussing risks and benefits, just like we should be discussing the risks and benefits of birth control pills and SSRIs. GLPs are very much a mental health medication and an endogenous substance that we are still learning quite a bit about. They've been around a really long time, but they've exclusively been used back, decades ago for diabetes. And so we're just learning how to use them now for hedonistic eating, for example, which is eating out of pleasure. And so if somebody is a hedonistic type eater and they find just immense joy in food and that became the thing that they indulged upon, and you squash that hedonistic urge, you may be squashing a few other urges along with it. And so it's important we screen for that and prepare our patients that might happen.
The next best step would be to reduce the dosage.
Yes, and augment too. I mean, again, we can't just be one-trick ponies in healthcare. We've got to learn to mix and match and personalize our medicine to the individual who's sitting in front of us. And really good clinicians with experience know how to do this intuitively. But I think for those who are just learning, right, like just to start to pay attention to and be curious and ask the questions of your patients that they may not bring up, because I can tell you right now, in a woman who's feeling really good in her size 2 jeans that she couldn't fit into for 20 years, she's not going to tell you that this also has destroyed her sex life because she's afraid you're going to take that GLP-1 away from her. So you really have to be sensitive and bring it up, but also bring it up with the idea that we're going to augment. Maybe that's a great patient who could, also benefit from testosterone or a little bit of hormone therapy, which, by the way, also work in the brain and help with motivation, confidence, vitality, energy. And when you get that ratio right of those 2 things, they may be able to maintain the weight loss or, and feel a little bit, they're in a place where they can feel good about the dosing in a way that still allows them to enjoy and be present and have a quality of life that is suitable.
Do you recommend prescribing then the testosterone, the estradiol with right when you begin the GLP-1, or do you recommend waiting it out a little bit?
I mean, when a patient comes to see me, it's a conversation about how we're going to introduce these things. And at this point, I pretty much consider GLP-1s, especially in a microdose, to be a form of hormone therapy, especially for anyone over the age of 35, as they not only improve your overall weight, but they're lowering inflammation, which is a huge issue for women as they start to lose their reproductive hormones. We see spikes in inflammation. It's improving your cardiovascular health. It's setting you up to not be bloated every time you eat something.
Right.
There's so many ways that it works. And so I do introduce it, but I find that I'm also at the same time getting a hormone panel, checking testosterone levels, and often microdosing and then potentially, introducing testosterone as a fast follow and bringing my patient back often to have conversations about what's working and what isn't.
Okay. Do you worry that we haven't had enough testing around the long-term effects of GLP-1s? Because I totally hear you on the microdosing benefits, but one thing that I've heard more and more people express is the worry that they haven't been around long enough for us to truly know its impact long-term. What do you say about that?
Yeah, this is an interesting argument, and I have moved my position on it a little bit, I would say, in the past year or so. That's just for using it in different ways and in more and more women in particular. A lot of women are worried that they're never going to be able to come off of it. I think that causes a lot of hesitancy in starting it, and I can understand why that would be. I don't worry about it being a safe medication. We have 2 decades worth of data on this class of liraglutide, for example, has been around since the 90s. So we are not new to this class of medication. So I know that it's safe, and we know that it's effective for what it's been studied to do, which is improve insulin resistance in type 2 diabetics and help improve body composition and overall BMI in patients with obesity. But we are using it off-label. We are using it off-label in a whole host of other ways at this point for perimenopause management, for the management of addictive disorders like gambling, for example, and ADHD. We're using it to treat IBS. We're using it for PCOS, alcoholism. I mean, there are
shopping addiction,
social media. And it works for those things, right? And so it's very tempting to offer it, but we don't. And we haven't studied it, and I know that that's such a triggering phrase because we're probably not going to study it for those things for a long time. And hormones also were not studied appropriately for many years. So it's kind of an inflammatory statement. I get that. But what I don't fully have conviction around is, yes, how would it be if somebody does want to transition off of it at some point? Do we get a rebound hunger, for example, that is, going to be a problem for somebody to where they're going to gain all the weight back. And I have seen that happen in patients who do not use it for long enough and then, go cold turkey, or used it inappropriately to begin with, lost all their muscle mass, and then tried to stop it. And now they're in a worse situation than they were previously. So we haven't standardized the way that we look at these things, and we know nothing about microdosing, right? So I always counsel my patients that there's things we do not know.
Right.
I also am starting to see in some patients who have gone on and off of them over time a little bit of, and this is very new and again, very anecdotal, zero data. This is my N of one as a clinician. A little bit of resistance start to build up, meaning that patients will maybe start to gain a little weight back and think, oh no, this is not happening. I'm going right back on. And then the GLP doesn't always work as well as it did the first time.
Okay.
And that's very unsettling. And I know we have a lot of other GLP-1s in the pipeline. They're all coming out as branded medications for obesity, as they should. But again, we have not studied them for other things, and they're going to be used off-label because that's what's happening in healthcare right now. And so I think it's the wild, wild west, and there will be people who fall through the cracks and have unfavorable outcomes.
Right.
But if we're not studying this and we're not looking at this more broadly, what's the real-world evidence? How do we gather that real-world evidence, not just off of a Reddit forum, but like in a meaningful academic, scientific way, and start to look at this? Like that's where I think I'm super interested in paying more attention.
I personally took GLP-1 so that I could lose 14 pounds that did not want to come off, and that I do feel like is just the slowing of my metabolism, even though all of the other factors were equal, right? I was working out the same, eating the same, all the things.
Yep.
So one of the side effects that I had, I microdosed on it because my body had a very acute reaction right away. And so my provider decided to reduce it very quickly after the first couple of weeks. But I lost that amount of weight, those 14 pounds, within 4 months. And one side effect that I had that I did not realize could be from this, and that everybody was just like, oh, it's aging, like your hormones, aren't the same, is huge amount of hair loss. And I have so much hair, and it was just frightening to see clumps of hair come out. I feel like that isn't talked about enough, especially because hair for women is such a defining part of our aesthetic and how good we feel about ourselves. What do you recommend for clients? Because I know that you do have a whole hair protocol that you share. Can you talk a little bit more about that?
Yes. I mean, I've never been asked in my clinical life so much about hair loss, and we are seeing it in droves. We are seeing women, to your point, freak out that there is like a pile of hair in the shower, or they get out of the shower to comb and it's just copious amounts of hair coming off their head. And I think you're right. I mean, GLP-1s work in a lot of ways, but when we're not eating as much food, the body sees that as a stressful experience, whether it's happening fast or slow, right? Weight loss is a stress on the body. And we don't have great research around this, but what we do know is that the body, we think, is trying to conserve its calories and sort of redistribute where energy is going. And it doesn't see hair as sort of a meaningful usage of that energy.
Interesting.
And so that's one theory. Of course, too, there is this idea that, iron, there's your iron, your zinc, your copper, your selenium, like all these micronutrients that we're not getting, that the hair follicle itself might be starved of. We're, seeing blood flow rerouted to different places away from our scalp. And I think, it's also just the time of life. Many women who are using GLP-1s are over 35 and their own hormones are also in decline at the same time. So it's this confluence of many reasons, estrogen, progesterone. Absolutely. It's why when you're pregnant, you have this lush, thick, gorgeous hair. You have these high levels of estradiol. And estradiol, like the garden analogy I described earlier, also makes your hair grow lush and thick. And it's a hormone that helps with, it's a growth hormone in many ways.
Yes.
So I think it's the confluence of all of that. And I think that I'm seeing it more with Tirzepatide, I bet you we're going to see it even more with our new sister who's coming out, retatrutide or retatrutide, just because these work in stronger, more powerful ways.
Right.
And so I am pretty proactive with my patients about addressing hair and hair loss. Reminding everyone too that I also prescribe quite a good amount of testosterone to patients, which also one of the risk factors of taking testosterone, even in physiologically optimal levels, is hair loss in certain more epigenetically prone individuals. Those with a family history of, that skirted eggshell situation that the men have. Like women can lose hair for, in androgenic alopecia is the diagnosis.
Okay.
And that is a different type of hair loss than the stress-related hair loss, which is called telogen effluvium. So it's often, again, a combined approach of minimizing the exposure of androgens or testosterone to the hair follicle through androgen blockers, like, anything from saw palmetto, which is a supplement, all the way up to spironolactone, which helps block the conversion to DHT in the scalp. And then making sure nutrition and gut health are really dialed in, making sure you're getting enough protein, making sure your iron stores are adequate. So many women in midlife have heavier periods, like we talked about, due to the loss of progesterone. And when you're bleeding heavily every month, you're losing tons and tons of iron store. So it shows up as low ferritin. So I often am testing for those things. Any kind of inflammation we need to mitigate. So I check an HSCRP, a homocysteine, and really work on anti-inflammatory diet as a strategy also for hair. Supplements, there are many of them. We do not need as much biotin as some certain supplement companies are saying that we do. There's not such a thing as biotin deficiency in many women.
Right.
And having that much biotin can also be problematic for many other reasons. So finding a supplement that has the right amount of biotin in it and has that right combination, making sure your nutrition is good, making sure you're holding on to that muscle, right? The second you start losing muscle, that is like your body is waving that white flag and the hair is going to fall out. So strength training, it's really all of that.
Right.
Yeah. And there's newer, cooler therapies too, red light therapy, topical peptides, for example, like GHK can be helpful.
So I want to talk to you about that because let's talk about peptides and how they differ from hormone replacement therapy. Because when I was losing all my hair, my hairdresser goes, "You should take GHK, the beauty peptide." And I'm like, what is that?
I love that your hairdresser said that, by the way. I think hairdressers are like an untapped market for hair loss because think about it. They know your scalp better than anyone.
Yes.
And they see you back every 6 to 12 weeks. So it's like having a doctor, but in the salon chair. You asked me the difference between peptides and hormones to start. And so they're similar, but quite different. So hormones are, made in one part of the body and travel to another part of the body and kind of work everywhere. There's an estrogen receptor literally on your toenail and your eyeball. So they're kind of this just workhorse, and they have different effects everywhere they go. Peptides are much smaller molecules. They're chains of amino acids that are signaling molecules. So they tend to work more locally. They're also very short acting, so they're cleared very fast. So you can often inject them, which is why they need to be injected, because they need to go sort of to a local area, be in the body very quick. Teach the body or speak to the body in such a way that it is helping the body to do something it already knows how to do, just smarter. So work smarter, not harder. And that is a different strategy. And so these are not molecules that are meant to be used all the time, forever and ever, like hormones are in the case of hormone therapy, but rather for specific indications. So to your question about GHK, yes, that has many functions actually, but one of the best, most touted kind of benefits of GHK is its effect on collagen production, hair, skin, nails, that glowing look. So we love that. We love that. And hence the name, the beauty peptide. It can be absolutely used topically. So I love compounding it in like a face cream or using it topically on scalp for microbiome optimization and hair regrowth and follicle health. We have great topical data on GHK. We have not yet studied GHK as an injection to be used, and so we're extrapolating the data we have. So again, a little bit of the Wild West with peptides. Many people are injecting them safely, and so real world evidence is what we're relying on here. But yes, it is a powerful molecule even beyond hair and skin in the way that it modulates gene expression, for example. So we have lots to learn about GHK as a peptide.
Okay. But it's really important to work with a medical provider instead of purchasing them off of
dear
a
God, yes.
add to cart website.
No add to cart, please.
Yeah.
Yes. I mean, we're in this wild time right now with peptides and the regulatory space. There are many peptides that we've known about a long time, right? No surprise, insulin, hello, is a peptide. But these newer peptides, these lifestyle peptides, as we're saying, that help with things like energy, recovery, brain fog, sleep, mood, sex, etc. These are kind of right now being treated like supplements on the market and are actually in a category of drug called category 2, where it's technically illegal to compound them. And so it's created this gray market and this loophole where people are able to access them as research use only or physician use only. Those are the things you can buy online today without a prescription. And there's absolutely no safety testing, purity testing. You don't know if what you're getting, is going to have an endotoxins in it, for example. So you're injecting something straight
That's
into your blood.
scary.
It's very scary. And there's a huge demand for these. And so we're about to see in the next 6 to 12 months a massive shift in how they're regulated, how they're accessed. And so as of today, we're recording this in May of 2026. We need to make sure that the provider, the prescriber you're working with, works with compounding pharmacies that are reputable, that are transparent about their processes, are willing to hand over a certificate of analysis to prove that that is true, and have a reputation of having done this, not just, started it yesterday. And so those are interview questions you should have for your provider for sure if you're seeking peptide therapy at this time.
Okay. That is very helpful. Now, I want to talk about PT141, which is like the libido peptide.
Yeah.
Tell me more about that.
So this is not a new peptide. She's been around the block quite a while. In fact, we have her as an FDA-approved medication.
Oh, fantastic.
We do. And I'm sure you've heard about Vyleesi.
Yes.
So PT141 is essentially the same thing as bremelanotide, which is the FDA-approved pharmaceutical for hypoactive sexual desire disorder in women.
Which is basically to treat low libido for women.
Exactly. And that there is a diagnosis for that. And so you can diagnose someone and then there is this drug to prescribe to them. Right. And that is a wonderful thing. We can use PT141 off-label. We can use it in men, for example, for delayed ejaculation because it really is more of an arousal peptide than it is technically a libido peptide. But for women, arousal is the gateway drug to libido, right? Women need to be physically experiencing a sexual stimuli and then their brains turn on, which is libido, versus men, which get to have, they have to technically have libido first, or the thought happens first and then the body follows. And so I love PT141 for women who feel like they want it, but they put themselves in sexual situations and kind of nothing's happening, or they're starting to feel like their bodies are warming up to stuff, but maybe they can't climax. I really do like PT141 a lot in that setting specifically, even though it's on brand for libido.
Can they pair that with SSRIs? Because one of the things that I do hear is also not just like a lack of desire, but a lack of ability to orgasm on SSRIs.
Absolutely, yeah. SSRI-induced sexual dysfunction. It pairs nicely with that. It also pairs nicely with GLP-1s for the same reason.
Oh, interesting. Okay.
Yes.
And so one of the things that I found so interesting is that when Viagra was approved by the FDA, the way that it functions, obviously, is to direct blood flow to the genitals, right? But these medications to treat low desire for women, actually, they don't work with blood flow. They work in the brain.
For the most part, yes.
Yeah. And there's Addyi, there's Vyleesi, and then there's PT141.
Yep.
How do these three differ?
So Addyi, we'll start with Addyi. Addyi is flibanserin. Interestingly, your story about Viagra. Viagra came to market in 1995 or something like that. It was a long time ago, and it was 6 months, introduced the medication, and then it was approved. And Addyi did not approved until 2015, and it took 6 years and 2 FDA rejections in order to get it to market. And even then it came to market with an inappropriate black box warning about alcohol. So you could see right there the hypocrisy in on our care for women's sexual health just alone, and we could have a whole episode about that. But that one works by modulating, Addyi does, directly in the brain. So it modulates serotonin and dopamine production directly in the brain. And so that we see on MRI in women who have this feeling that their brain just won't turn on, that they have sex, they get into it, climax is there, everything feels pretty good, but their brain is just not in it. And it's not for any other reason, like you hate your partner, right? Or you're taking a medication that is completely wiping you out, right? So in those women, yes, Addyi is approved, and it was previously only approved, inappropriately so, but that's how it was studied, for premenopausal women. And we just in December had it approved also for postmenopausal women, which is a huge win and democratizing access, because Addyi works in the brain. It doesn't work on your hormones, so it shouldn't matter whether you're pre or postmenopausal. So that's the Addyi story. And then Vyleesi, as we talked about, PT141, also does work on melanocortin receptors, which we have all over our body, in our brain, in our gut. And the augmentation of the melanocortin receptor, it also improves dopamine production as well, helping with that approval and arousal.
Yeah, that's great that women have options.
It is. It really is. Yeah.
And it's not talked about much, even though that they have been approved by the FDA for, almost a decade now.
That's right. So yeah, I mean, to your point about peptides, we have many that are not on label or FDA approved, but we have many peptides that are, available to us. And, you can get Addyi as a branded medication. You can get it from a compounding pharmacy if you want to do more precise dosing. And I use that strategy sometimes in my female patients who, want to try something and are a little bit worried about how it will suit them. I often will compound PT141 before prescribing Vyleesi to them so that they know how they feel with it.
Okay, perfect. I also think it would be a disservice if we did not talk about vaginal estrogen very quickly, because I have a friend who is in her late 40s. She was having very painful recurring UTIs, and her medical provider did not mention to her that vaginal estrogen could be something that could help. And vaginal estrogen is really helpful with genitourinary syndrome of menopause, which ends up causing vaginal dryness, pain, and even the disappearance of your inner labia, right? Your labia minora.
Yes.
Why are we still so hesitant about talking about it, prescribing it? It seems like just so few women know about it. And there's still this worry that it can cause breast cancer when it absolutely is, risk-free in that regard.
It's one of the few treatments we have for anything that I can almost exclusively say is risk-free. I mean, think of Tylenol is not risk-free, right? And so it's wild to me that we're still in this place. And mostly it has to do with this, the fact that we can't have these conversations. We can't market these medications without, being sort of, shut down online. Like, I have to be really careful about making social media reels. I can't use the word really vulva or clitoris or orgasm. And we both know this well. So we can't have these conversations outside of a clinical setting. Women are embarrassed to bring it up. Most women have no idea what their vulva is versus their vagina. I personally don't even like vaginal estrogen as much as I like vulvar estrogen, because we're teaching women to take these kind of yucky creams and tablets, to be honest, that aren't that luxurious to use in the first place.
Right.
And we just tell them to use these yucky applicators, which are like tampon applicators, and then reuse them, which is gross. And basically just, we don't teach them anything about how to make this work for them. What I love to do is actually use a combination of both estrogen and testosterone in the vulva, because the vulva is rich in androgen receptors. And that is, again, not discussed, and we don't teach gynecologists, really anyone, about it. And sort of a more intentional application of a nice product in that part of the body not only prevents dryness and irritation and UTIs, but can improve sexual function, right? Yes. By improving arousal, lubrication. And these things can be used proactively. You do not have to wait to be dry and in horrible pain. They can be used in patients with a history of breast cancer. That conversation, needs to be put to bed as well. And we need to be democratizing access to them and not making them so hard to get. They should be over the counter, in my opinion.
Yeah, absolutely. I agree with you. Now, I want to end on this note with you are doing a home renovation, and I wanted to learn a little bit more about how you're restructuring it so that it supports your sexual health and your connection with your partner at the stage of your life.
Yeah, thanks for asking. I mean, I'm renovating this house and we're doing this big renovation, and I'm thinking to myself, what are the ways that I want to set my home up, not only for my wellness today, but kind of like for my own longevity as a home we're going to stay in for a long time. And as our kids are growing up and potentially, eventually leaving the house, hopefully they leave at some point, and want to come back, right? And then we're back to, just being my husband and I in this house. Like, what does that look like for us? And so I have, thought of these sort of 6 S's about the way that I want to think about each room in my house. And sex is certainly one of those. And so, I mean, we could go on and on about this, but I think for me, one thing is that there's the bed, right, and the bedroom, and it is like sort of my least favorite place to have sex because it's so expected, right? And women need novelty and anticipation. And why are we having like this leftover sex at 11 p.m. at night when you've gone out to dinner and you've overindulged on wine and food and you feel kind of bloated and all you want to do, but every woman I know just wants to come home and, watch a show and go to sleep, right? The last thing they want to do is have to have sex, and you already know it's expected. So let's just like get rid of that, right? Instead of like having sex when we're getting undressed, like what about thinking about having sex as you're getting excited for your evening? Like what if you've got a walk-in closet that you guys with a lock on the door and a bunch of really good mirrors and lighting and surfaces, and it doesn't just have to be for your shoes like Carrie Bradshaw said. It could be for a whole lot of other things. So
I love that.
Something
Kinky
like that.
Jackie.
I mean, just try to make it happen here, Natassia. And I think that's pretty, I'm not that different than a lot of my patients. I'm pretty honest about the challenges. I mean, we're both really busy entrepreneurs, and
of course
it has to be intentional. And if we're designing homes that sort of remove the friction that are set up to engage us in ways that actually are physiologically advantageous, TVs in bedrooms probably need to go. Phones in bedrooms probably need to go. Oh, yeah. I love music in my house everywhere while I'm cooking, but also in a bedroom, right? And I actually created I think you saw this too, but a playlist with a DJ who's a therapist who studies how the BPM of music can actually influence our mood and our physiologic health. Very much, right? And so I'm like, well, what if, and I stole this from a pasta playlist from Barilla Pasta. Have you heard of this?
No.
So Barilla Pasta did this genius thing where they created playlists that were the exact number of minutes timed to the number of minutes it would take to boil and cook their individual pastas.
Oh, interesting.
And then put those out. So you could hit, play my rigatoni playlist.
That is hilarious.
And you wouldn't have to have a timer. And I thought that, first of all, that's so genius. It's the best marketing I've ever heard of.
Yeah.
But I was like, well, what if we did that for women's sexual health? Because we know women take a lot longer to get to arousal and orgasm than men do, and they need, the worst word in the world, foreplay. And so what if we created a playlist that evolved through the different BPMs to exactly a number of minutes, which we decided was 22, for women to sort of not only, pace themselves, but have their own sort of like their own timer. And then we made it really fun and novel and kind of evoke that like late 90s, early 2000s musical genre that was the music I was listening to when we were like putting our tube tops on and getting ready to go out in New York City, in 2002. And so it's this idea that like music allows us to really get into our bodies and out of our heads. And that is always the challenge.
And dancing.
And dancing. Like if we can go there and again, setting up. So if you have a sound system installed in your bedroom and you can just say like, hey, play my whatever playlist, and it just comes on, maybe we're removing some of the barriers to
Yeah,
entry.
you're finding a way to transition and bridge that gap into a more sensual mindset. I love that.
Yeah. So those are my thoughts. I'm sure others will come up as the planning process evolves. But
Yeah, I'm so excited to see that.
Thanks.
Well, Jackie, thank you so much for coming on. We're going to be linking all of the ways that people can reach out and work with you, but I will already preface that you can work with Jackie by heading to her website, JackieGiannelliNP.com. We're going to link that in the show notes. And I'm so excited to work with you as well.
Yes, thank you. I love talking all things sex with you all the time. It's so easy and comfortable, and this has been my pleasure.
Thank you for listening to Less Than Translation. If you enjoyed this, please hit follow wherever you listen and leave a review. It helps more people find us, and it means everything. See you next week.